Hello everybody and welcome to our module on platelet disorders. An easy way to group bleeding disorders in your mind is to think of them as those that result from abnormal coagulation, those that result from abnormal platelet function, and those that are a mixture of the two. In another module, I talked about abnormal coagulation, bleeding disorders like hemophilia and vitamin K deficiency. In this module, I'm going to talk about platelet disorders and also disorders that involve a mixture of the coagulation system and the platelets. Let me first give you a rule of thumb related to the types of bleeding that occur in different bleeding disorders. When patients have a problem with their platelets, the bleeding problems tend to be superficial. For example, they will have bleeding from mucosal surfaces. This may involve nosebleeds, or women may have menorrhagia. They may also have superficial skin bleeding, and they commonly get a characteristic skin finding called petechiae. This is a picture of petechiae on the screen here. They're small red dots, and this is caused by the extravasation of red blood cells from capillaries, and that's what happens when your platelets don't work properly. On the other hand, when patients have problems related to the coagulation cascade and coagulation factors, they tend to get deep tissue bleeding and joint bleeding. This is the kind of bleeding you see in patients who have hemophilia. So this is just a rule of thumb, but it's helpful especially in board questions that describe bleeding symptoms. There's a test of platelet function called the bleeding time that's abnormal in many platelet disorders. This is a test that's rarely done in the modern era. It used to be done years ago. To perform this test, you make a small cut in the skin on a patient's forearm. You then apply filter paper and remove it at regular intervals until the filter paper comes off clean, indicating that the bleeding had stopped. You then record the time it took for the bleeding to stop, and that time is called the bleeding time. The reason this was an effective test of platelet function is because you really need your platelets to stop superficial skin bleeding like this. This test doesn't depend much on the coagulation factors, so when the bleeding time was prolonged, it indicated there was some problem with platelet function. So I'll start this module by talking about 3 inherited platelet disorders. Children are born with these conditions, and they often present at a young age with bleeding problems. The first disorder is Glanzmann's thrombocythemia. This is a genetic disorder that is transmitted through families in an autosomal recessive fashion, and children born with this disorder have a functional deficiency of the 2B3A receptors found on their platelets. This will lead to mucosal platelet-type bleeding, often epistaxis, in childhood. And the key diagnostic findings of this disorder will all make sense to you if you understand what the 2B3A receptor does on platelets. Remember, that is the platelet receptor that allows platelets to link together and aggregate to form a platelet plug. So one of the diagnostic findings is a prolonged bleeding time. In addition, on a blood smear, you will see isolated platelets with no clumping. This is very unusual, and when you see this in a child with epistaxis or mucosal bleeding, it raises the possibility of this condition. And then finally, you can test the ability of platelets to aggregate in response to various stimuli doing a test called platelet aggregometry. So in this test, platelets are mixed with stimuli that should make them clump together. These are things like ADP and arachidonic acid. And what you will see in Glanzmann's thrombocythemia is that the platelets will not aggregate normally, and that's because they are missing or deficient in functional GP2B3A receptors. The second disorder is called the Bernard-Soulier syndrome. This is also an autosomal recessive disorder, and in this disorder, children have a deficiency of the glycoprotein 1b platelet receptor. And once again, the reason this rare disorder can come up on the USMLE Step 1 exam is to test whether you understand what the glycoprotein 1b receptor normally does. And recall that that is the receptor on platelets that's important for binding to von Willebrand factors so that the platelet can adhere to damaged endothelium. Another feature of this disorder, which is just sort of peculiar, is that it also results in large platelets. The reason the platelets get large is poorly understood, but key findings in this disorder include large platelets on peripheral smears. These children often develop bleeding. Once again, it's the platelet type of bleeding. It's often mucosal bleeding. It presents as epistaxis or menorrhagia. Key lab findings are prolonged bleeding time, as you would expect from a platelet disorder, also thrombocytopenia and large platelets on blood smear. Giant platelets can be seen in association with thrombocytopenia in a number of very rare inherited platelet disorders. Bernard-Soulier is one of them. This is a picture of a giant platelet shown on the screen here, and when a hematologist sees this on a peripheral smear, it alerts them that they may be dealing with one of these rare inherited platelet disorders. Our final inherited platelet disorder is the Wiskott-Aldrich syndrome. The thing to remember about this disorder is that it involves platelets, and it's also an immunodeficiency syndrome. So it occurs in infants. It's an X-linked disorder of the WAS gene, resulting in an abnormal WAS protein, and this protein is important for T-cell cytoskeleton maintenance. For that reason, these patients have immune dysfunction. They also have low platelets, and they also have eczema, which is a skin rash. This is a very unusual triad. This is a very rare disorder, but if you see this triad, the thing to think about is Wiskott-Aldrich syndrome, and I talk about this in more detail in some of the immunology modules. Now I'm going to move away from inherited platelet disorders and talk about acquired platelet disorders, and we'll start by talking about ITP, which is idiopathic thrombocytopenic purpura. This is a disorder of decreased platelet survival where for one reason or another platelets do not live as long as normal, and that leads to an overall decrease in the supply of platelets in the bloodstream. There are a number of reasons why platelets don't live as long as normal in ITP, but one of the most common is because of anti-2b3a receptor antibodies. By way of review, all platelets express the 2b3a receptor in an inactive form. When the platelets become activated, the receptor changes conformation, and this allows platelets to adhere to one another and form a thrombus. When antibodies develop to these 2b3a receptors, that leads to consumption of platelets by the splenic macrophages. So what you want to remember in terms of step one is that one of the most common reasons for ITP is antibodies to 2b3a, and that splenic macrophages are the source of platelet destruction. ITP is generally a diagnosis of exclusion. You need to rule out other causes of low platelet counts, especially bone marrow suppression. Once you do this, then that proves that something is causing the platelets to be consumed in the spleen, and that is the definition of ITP. The treatment can involve steroids, which can knock down the production of antibodies. In addition, IVIG is sometimes used. IVIG is pooled immunoglobulin from donors, and the immunoglobulins can block the Fc receptors on macrophages in the spleen. So a macrophage in the spleen may have an Fc receptor, and this can bind an antibody that's stuck to a platelet. However, if you administer IVIG, it will block that Fc receptor, and then the macrophage won't consume the platelet. Another treatment that's commonly done for severe ITP is splenectomy. You can live without your spleen, so the spleen will be removed, and then the patient will see a rise in the platelet counts. Our next platelet disorder is called TTP, and the name sounds a lot like ITP, but they are completely different disorders. TTP is a much more dangerous and serious condition. TTP stands for thrombotic thrombocytopenic purpura, and what this means is that in addition to low platelets and purpura, like you can see in ITP, you also have thrombosis, and that's what makes it a more dangerous condition. This is a disorder of small vessel thrombus formation. Thrombus forms in small vessels and consumes platelets, and this leads to thrombocytopenia. And the underlying cause of TTP, which we'll go through in the next few slides, is decreased activity of the von Willebrand factor cleaving protease called ADAMTS13. In order to understand ADAMTS13, we have to review the structure of von Willebrand factor. Recall that von Willebrand factor is very important for normal platelet hemostasis, and von Willebrand factor is a protein. It's synthesized as a monomer. This occurs in endothelial cells and megakaryocytes, and that's why you can find von Willebrand factor stored in endothelial cells and also stored in platelets that derive from megakaryocytes. The monomers then link together in the endoplasmic reticulum, and they become dimers, and then in the Golgi apparatus, the dimers link together and form large structures called multimers. So you should think of von Willebrand factor as a collection of polymers that are linked together to form these large multimer structures. The large multimers are stored, as I mentioned on the last slide, in the Weibel-Palade bodies of endothelial cells and also in the alpha granules of platelets. When they are released into the plasma, these large multimers can obstruct blood flow. The reason this doesn't normally occur is because of ADAMTS13. It's an enzyme, it's technically a metalloprotease, and it breaks down the multimers of von Willebrand factor and prevents thrombotic occlusion. The structure of von Willebrand factor and its interaction with ADAMTS13 is highly complex. What I'm going to show you on this slide is a simple way you can think about this process to understand TTP. So von Willebrand factor is released as a multimer, and if ADAMTS13 is doing its job, it will break down that multimer into smaller pieces which can then interact normally with the platelets. What happens in TTP is that there is deficient activity of ADAMTS13. This leads to a buildup of the multimers of von Willebrand factor, which pulls in platelets and forms an obstruction in the small blood vessels. So the cause of TTP is a severe deficiency of the ADAMTS13 enzyme. Usually activity levels are less than 10% of normal among patients who develop TTP. The reason this usually happens is because patients develop an acquired autoantibody to the ADAMTS13 enzyme. I've shown you that in the picture at the bottom of the screen to help you remember that. As a result of low levels of activity of ADAMTS13, patients accumulate von Willebrand factor multimers, and the multimers most like to accumulate in areas of high shear stress. And the part of the vasculature where the shear stress is highest is the small blood vessels, and for this reason you develop obstruction of the small blood vessels. When the small blood vessels are obstructed, a special type of hemolytic anemia occurs called microangiopathic hemolytic anemia. Most people call it MAHA. This looks like any other hemolytic anemia with increased LDH levels and low haptoglobin levels. However, there is one special feature, and that is the presence of schistocytes. These are schistocytes shown in this blood smear here. They look like fragments of red blood cells, and these are formed by the shearing of red blood cells as they pass through a narrowed portion of the microvasculature, which is obstructed by thrombi. And you can see microangiopathic hemolytic anemia and the presence of schistocytes in TTP like we're talking about now. You can also see it in hemolytic uremic syndrome and disseminated intravascular coagulation. We'll talk about these two disorders later in this module. So what does the clinical presentation of TTP look like? Well, first of all, fever is one of the hallmarks. This is because there is inflammation from small vessel occlusion and tissue damage. Another hallmark is the presence of neurological symptoms. These include symptoms like headache and confusion and seizures. These are from small vessel occlusions occurring in the central nervous system. Patients can even have focal neurological deficits. Small vessel occlusion in the kidneys leads to renal failure, and then finally petechiae and bleeding develop from the low level of platelets. Now that clinical presentation is somewhat nonspecific. A patient with fever and mental status changes and renal failure doesn't necessarily make you think of TTP right away. What usually clinches the diagnosis is the results of lab testing. So lab testing will show evidence of a hemolytic anemia. There will be low platelets, as the name of the disorder implies, and schistocytes will be seen on blood smear. Importantly, the PT and PTT tests of the coagulation system should be normal, and this is an important distinction between TTP and DIC. In disseminated intravascular coagulation, which we'll talk about in a minute, there are also thrombi formed throughout the body, but in DIC those thrombi consume the coagulation factors and prolong the PT and PTT. The thrombi that form in TTP are primarily made up of platelets, and therefore they do not consume clotting factors, and the PT and PTT usually remain normal. You can see an elevated D-dimer, however, in TTP, and this is because there is still some formation of fibrin and some breakdown of fibrin, enough so that the D-dimer level can become elevated, but not so much formation of fibrin that the coagulation factors become consumed, as you see in DIC. Now let's talk about a related syndrome to TTP, and that's the hemolytic uremic syndrome, or HUS. This syndrome shares many similarities with TTP. For one thing, it is also caused by platelet-rich thrombi that form in small vessels. This leads to a microangiopathic hemolytic anemia, just like in TTP. The platelet count is also low, just like in TTP, and you will see acute kidney injury. That's why it's called the uremic syndrome. Usually, however, there is no fever or central nervous system symptoms, and that's what distinguishes hemolytic uremic syndrome from TTP. You can think of it as being TTP that's focused only on the kidneys. So you get renal thrombi, this leads to kidney injury, but you don't see the signs and symptoms that occur from thrombi outside the kidneys, such as in the central nervous system. An HUS commonly is seen in children, and it usually follows a diarrheal illness caused by E. coli 0157H7. This bacteria produces a Shiga-like toxin that leads to the formation of the microthrombi that result in the hemolytic uremic syndrome. So now let's talk about disseminated intravascular coagulation, which is also called DIC. This involves widespread activation of the clotting cascade, leading to diffuse thrombi, and in contrast to TTP, the thrombi in DIC contain both platelets and fibrin. This leads to ischemia. It also leads to the consumption of clotting factors. So as we will see, the PT and the PTT get very prolonged in DIC. In addition, the platelets are consumed much like they are in TTP, and you get low platelets. And then finally, because of the clots formed in small blood vessels, there is microangiopathic hemolytic anemia and destruction of red cells. DIC always occurs secondary to some other process, so let's talk about some of the conditions that can lead to DIC. First of all, many obstetrical emergencies can lead to DIC. A DIC is a feared complication of problems related to childbirth. So, for example, women who have abruption of the placenta can develop DIC. Also, women who have major hemorrhage after delivering a baby can sometimes develop DIC. One of the reasons for this is that amniotic fluid contains tissue factor, which can activate the coagulation cascade, and for this reason, DIC is often seen in conjunction with a rare complication of pregnancy, which is amniotic fluid embolism. DIC also commonly occurs secondary to sepsis. One of the reasons for this is that many bacteria contain endotoxin, which can activate the coagulation cascade. In addition, when patients are septic, they often have very high levels of cytokines, and this can trigger DIC. Cancer can lead to DIC, especially leukemias. Acute promyelocytic leukemia, or APML, is a common trigger for DIC. And you know that cancer is a well-described hypercoagulable state, so you can just think of DIC as resulting from excess coagulation that goes along with cancer. In addition, rattlesnake bites have been described as causing DIC. There are some snakes that contain thrombin-like glycoproteins in their venom, so if they bite you, this can lead to diffuse activation of clotting, and DIC can develop. DIC presents as bleeding in the setting of the primary illness. So, for example, a woman with an obstetrical complication who develops bleeding may have DIC. You make the diagnosis through lab tests of hemostasis, and the easy way to remember all the blood test abnormalities is to just remember that every blood test you can think of for hemostasis will be abnormal in DIC. For example, there's consumption of clotting factors in the diffuse thrombi. This can lead to prolonged PT, PTT, and thrombin times. There's consumption of platelets in the thrombi, so the platelet level will be low. If you measure a fibrinogen level, it will also be low from consumption. There's evidence of microangiopathic hemolytic anemia, so the red blood cell count will be low. There will also be an increased LDH and low haptoglobin levels. There will also be schistocytes seen on blood smears. And then finally, if you measure the D-dimer level, that will also be elevated because there are diffuse thrombi which are being broken down and forming D-dimers. The main way you treat DIC is to resolve the underlying disorder. However, sometimes you need to treat the problems of hemostasis until the underlying disorder goes away. So, for example, fresh frozen plasma is sometimes administered to replace clotting factors. Transfusions of red cells or platelets are sometimes necessary, and sometimes cryoprecipitate is administered. Cryoprecipitate contains lots of fibrinogen, and it's a treatment for the low fibrinogen level. So there are 4 bleeding disorders that involve platelets. They all have 3 letters: ITP, TTP, HUS, and DIC, and they can sometimes be confusing, so here's a chart just to help you keep them straight. First of all, remember that ITP only involves the platelets, so there will be low platelets but nothing else. You won't see evidence of hemolytic anemia, and the coagulation test will be completely normal. In both TTP and HUS, you have low platelets as well as presence of a hemolytic anemia. You should not, however, see prolongations of the PT or PTT. They should both be normal, and that's what distinguishes TTP and HUS from DIC, which can also have evidence of hemolytic anemia and low platelets. Remember that the thrombi that form in TTP and HUS are platelet-rich thrombi. This is why the platelet level gets low, but coagulation factors do not get consumed. Then also remember that TTP has fever and confusion, which is usually not present in HUS, and then also remember that HUS will usually occur in a child following a GI illness. And then finally, in DIC, you have diffuse thrombi forming that contain both platelets and fibrin. For this reason, you will consume platelets. Their levels will be low. You will consume coagulation factors. The PT and PTT will be prolonged, and you will also have evidence of hemolytic anemia. Another cause of platelet dysfunction is uremia. When you have significant renal dysfunction, this can lead to platelet dysfunction and bleeding. The reason is because in the setting of uremia, there's poor aggregation and adhesion of platelets. This is caused by uremic toxins in the plasma. It's interesting, if you take platelets from a uremic patient and put them in normal serum, they will work just fine. The problem is not the platelets themselves, it's toxins that are floating around in the plasma. Exactly which toxins and how this happens is not well understood. But the result will be that the bleeding time will become prolonged. In fact, historically, one of the uses for the bleeding time was to test patients who were uremic to see if they had enough platelet function to safely undergo surgery. The platelet count will be entirely normal, and any tests of the coagulation system like PT and PTT will also be entirely normal. Another cause of platelet-type bleeding is thrombocytopenia. If you have a very low platelet count for any reason, you can experience platelet-type bleeding. One of the places you will commonly see this in the hospital is in the ICU or in the oncology ward. This is because patients there often have decreased production of platelets. So on the oncology ward, patients receiving chemotherapy or patients who have leukemic cells in their bone marrow will have underproduction of platelets. In addition, in the ICU, patients who are septic often develop bone marrow suppression as a component of their sepsis, and this can lead to low platelets. Another reason patients can have thrombocytopenia is from platelet sequestration, especially in the spleen. So patients who have splenomegaly can sequester platelets in their spleen. In addition, patients with portal hypertension commonly sequester platelets in their spleen and have thrombocytopenia. And then finally, you can develop thrombocytopenia if you have increased platelet destruction, for example, from ITP or TTP, as we've been discussing. So a normal platelet count is 150,000 to 400,000, and bleeding only occurs when the platelet level gets below 10,000, so it has to get very low for bleeding to occur. The treatment is platelet transfusions, and you'll mostly see this done on the oncology ward where patients have very low platelet counts from chemotherapy. The next disorder we're going to discuss is von Willebrand disease. This disorder affects platelet function as well as the coagulation cascade. As the name implies, this disorder involves deficient function of von Willebrand factor, which, by way of review, is a large glycoprotein. It's synthesized in endothelial cells and megakaryocytes and found in platelets, and it has two important roles in hemostasis. First of all, it is a carrier of factor VIII, which is part of the intrinsic coagulation cascade. So if you are deficient in von Willebrand factor, you will also be deficient in factor VIII of the coagulation cascade. Its second role in hemostasis is to bind platelets to the endothelium and also to other platelets. Therefore, if you're deficient in von Willebrand factor, you will have poor aggregation and binding of platelets. Von Willebrand disease is the most common inherited bleeding disorder. It's believed to affect up to 1% of the population. It usually results from some gene mutation, many have been described, that lead to low levels or low function of von Willebrand factor. Most cases are autosomal dominant and run in families, with males affected equally to females. Von Willebrand disease is usually a mild, non-life-threatening condition. It often results in easy bruising or skin bleeding. It can sometimes cause prolonged bleeding from mucosal surfaces. For example, patients with this condition can have severe nosebleeds, or women can have menorrhagia. And I've bolded the word menorrhagia because heavy periods is a common initial presentation of von Willebrand disease. If you suspect von Willebrand disease and you send the patient for routine blood work, you will find that the platelet count is normal and the PT is also normal. You may see an increased PTT. It depends on the severity of the disease. Remember that von Willebrand factor is a carrier protein for factor VIII. So if the level of von Willebrand factor is very low, then the level of factor VIII can also fall, and that will prolong the PTT. Usually this doesn't result, however, in serious bleeding consequences like you see in hemophilia. So you usually don't see the joint and deep tissue bleeding that you can see in patients who have hemophilia and are very deficient in factor VIII. And then finally, if you do a bleeding time, you will see that it's increased, but we rarely do bleeding times in the modern era, so you usually won't send the patient to the lab for this test. One of the tests used to make the diagnosis of von Willebrand disease is called the ristocetin cofactor activity assay. It's also sometimes called a von Willebrand activity level. Ristocetin is an antibiotic that was removed from the market because it caused low platelets. Ristocetin can bind to von Willebrand factor and also to the platelet glycoprotein 1b receptor. The result is that it will cause platelet aggregation if von Willebrand factor is present. So the way you do this test is you take a patient's serum and you add ristocetin. You then perform platelet aggregometry, which is a measurement of how much the platelets aggregate. If the platelet aggregometry is normal, this suggests von Willebrand factor is present and active. If it's abnormal, it suggests that von Willebrand factor is defective and ristocetin couldn't normally cause platelet aggregation. There are a number of treatments available for von Willebrand disease. One of them is to simply administer concentrated von Willebrand factor. Another is to use a drug called desmopressin. Desmopressin is an analog of antidiuretic hormone, or ADH. For this reason, it's sometimes used in diabetes insipidus. However, it also has another effect. It increases the von Willebrand factor and factor VIII levels in the plasma. It does this by triggering the release of von Willebrand factor and factor VIII from endothelial cells. For this reason, it's effective in von Willebrand disease. It's also sometimes used in hemophilia A, where the factor VIII levels are low. And then another drug that can be used in von Willebrand disease is called aminocaproic acid. This is an antifibrinolytic drug. It inhibits plasminogen activation to plasmin, and plasmin, as you may know, breaks down fibrin clots. So if you administer this drug, there is less breakdown of whatever clots can form, and therefore whatever von Willebrand factor is available in the plasma can be more effective because the clots that it leads to do not get broken down so easily. The last disorder I'll mention in this module is a rare condition called Hyde syndrome. This is GI bleeding that occurs in the setting of aortic stenosis. So in my field of cardiology, for many years, people noticed that patients with severe aortic stenosis often had lots of GI bleeding, and they wondered why this was the case. Well, first of all, it turns out that patients who have aortic stenosis have an increased risk of angiodysplasia. These are vascular malformations of the GI tract, and they're prone to bleeding, and they commonly occur in aortic stenosis, and that's one reason you get GI bleeding in aortic stenosis. And that's one component of Hyde syndrome. The other component is a deficiency of von Willebrand factor. This occurs because there are high shearing forces caused by aortic stenosis. As blood flows past that tight valve, there is uncoiling of the multimers of von Willebrand factor. This exposes the cleavage sites for ADAMTS13. So I told you that TTP is caused by a deficient activity level of ADAMTS13. In Hyde syndrome, you have overactivity of ADAMTS13. It's breaking down von Willebrand factor multimers and causing von Willebrand factor to be less efficient. So this also leads to the GI bleeding that is seen in patients with aortic stenosis. And all of this improves after aortic valve surgery. So Hyde syndrome is the condition of GI bleeding that occurs in the setting of aortic stenosis due to angiodysplasia and deficiency of von Willebrand factor. And that concludes our module on platelet disorders.